Hello, I hope everyone is fine, healthy and all well. So today the topic that we will be discussing that is approach to chronic liver disease in an elder child, and I hope at the end of this video you will be able to approach a child with CLD. Now what is CLD basically? CLD is a progressive destruction and then the regeneration of the liver parenchyma leading to fibrosis and cirrhosis. Now, at the start of every examination and approach, we must remember the wiper. W stands for wash hands, warm hands. I for the introduction. P for positioning the patient. E for the exposure. And R for the right side to approach for examination. Now, steps. There are 5 basic steps in approaching a child with CLD. The first one is the general look. The second one is the abdominal examination. The third one is the relevant GPE. The fourth one is the genitalia. And the fifth are some other that we can offer at the end of examination. Now the first one is general look. So what are the things that you will look in this step? The first one, that is whether the child is healthy or sick looking. Is he obese, thin, malnourished, average, tall, or of short build? Is he having any cannula, NG, Foley's, or oxygen? Are there any abnormal movements? Are there any signs of jaundice, pallid, cyanosis? Are there any skin rashes? Are there any purpura, petechiae, or scratch marks? The second important step, that is the abdominal examination, which further consists of inspection, palpation, percussion, and auscultation. So the first step, that is the inspection. Now stand at the foot end of the child and see the respiratory rate and the pattern of respiration, whether it is thoracoabdominal or abdominal thoracic. Then look at the shape, whether it is scaphoid, normal, protuberant, and then come to the side of the patient and see, is there no movement present? Is the abdomen moving with respiration or not? Then the first thing that you have to look for is the umbilicus, whether it is circular, inverted, normal, inverted. Are there any prominent veins? Are there any visible pulsations, any scars, any stria? Are there any pubic hair? And if present, so are they of the female pattern or of male pattern? Is there any gynecomastia, any spider nerve? And then tell the patient to look at the side and cuff to look for any evidence of hernia. Now in this picture, in this slide, the first picture shows the scaphoid, the boat-shaped abdomen, and the second one shows the distended abdomen. Now this shows the 3 types of umbilicus. The middle one, that is the normal inverted umbilicus, or the left one is the everted umbilicus, so the circular umbilicus, and the third one is the smiling umbilicus, the transversely slit umbilicus, which can be seen in ascites due to any cause. The first picture shows the prominent veins and the spider nerve. Now have a look at this video. Now this video basically is the step which is the inspection step, and over here the patient has prominent veins and we have to find out the direction of the vein, the direction of the flow, because that helps us to determine whether the direction is from the umbilicus to the periphery or from the periphery to the umbilicus, as the flow is from umbilicus to periphery in a star shape when there is cirrhosis resulting in portal hypertension. So there, and if it is away from towards the umbilicus, then that may be inferior vena cava obstruction or superior vena cava obstruction. So now the lady in the video that is showing that how will we know the direction. First of all, place your fingers on the vein, on the prominent vein, and then move them apart, and first release one finger and then release another finger to find out the direction of the flow as shown in the video. You can see now this is the prominent vein, and now she's milking the vein. Now she'll lift one of the fingers and see the direction of the flow. Now she'll lift another finger to see the direction of the flow. So when it is due to CLD or portal hypertension, so the flow that is from the umbilicus to the periphery, and when there is inferior vena cava obstruction, so the prominent veins will be below the umbilicus with caudal edema and edema in the legs, or when there is superior vena cava involvement, then the prominent veins will be present above the umbilicus and they will be swelling in upper parts of the body. Now come to the second step, that is called the palpation. In palpation, First of all, do superficial palpation in S shape so that you don't miss any quadrant, and look into the patient eyes, which will tell you is he is in pain or not, and which will further tell you that is the abdomen tender or not tender. After superficial palpation, we have the deep palpation, and move your hands with expiration. And in this step, you will find out that the abdomen is soft, is it tense, it is guarded or not guarded, is it tender or non-tender, is there any rebound tenderness present or not present. Then the third step in the palpation, that is the liver. If you find any liver, so first of all look for the edge. Is there any tenderness? See the surface. If the surface is smooth or nodular, is the notch present? How is the consistency? Is it firm in consistency, soft in consistency, or hard in consistency? Is there any left lobe palpable? Are there any pulsations? Is there any brew? And then you have to percuss the upper margin and measure the liver, the span of the liver. Then the fourth thing you have to palpate, that is a spleen. Now spleen, and the same things you have if you find any spleen, so you have to find that is there any tenderness, what's the surface, how's the consistency, how's the edge, the notch, the pulsations, the brew, and then measure the spleen. After spleen, palpate the kidney by the balloting method, and then the bladder, and then any lymph nodes. Now this video shows the palpation method. Now this is, first of all, this is a superficial palpation, but it is most accurate and more good if you do it in H-shaped pattern, so that won't let you miss any quadrant. Now she's doing the superficial palpation to check whether it is soft, it is non-tender, and by looking at the patient eyes. Now she will be doing the deep palpation after the superficial one, and now she'll look for the liver. She's looking for the liver, and here she found the liver. Now once found, she will look for the consistency, the surface, and the edge, any notch present or anything else present. Now she is over here. She look, starting from the right iliac fossa, she is palpating the liver, and here she found the border of the liver, and this is the border. Now she described the edge, the consistency, any tenderness present, this how's the surface, is there any notch. Now she has to measure the span of the liver. First of all, you have to tell that how many finger breadths it is below the right costal margin. You have to measure that, and after that you have to measure the whole span by percussing it. Now she is palpating the liver for finding out the features of surface, and these are the basic characteristics which I have already discussed, whether it is palpable or not. If it is palpable, what's the size, the surface, consistency, border, liver span, and the movement with respiration. If it is moving with respiration, it will be liver or spleen. But if the organ, if it liver or spleen is not moving with respiration, so that will be any other mass like intestinal mass. Now she'll be percussing the upper border so that she can measure the whole span of the liver. And here now she's going to start the percussion, and now she has to measure. The percussion will be started from the second intercostal space when she finds the upper border. After marking the area, here she found the upper border, and now she'll measure the span of the liver. So this was the most important step. Liver is the most important step because it is found in different diseases. Now she's looking for the spleen. Spleen palpation will also start from the right iliac fossa, and yes, here she found the spleen, and she found the spleen. Now she's looking for the surface, the consistency, the edge, the notch, and everything. She has to measure it below the left costal margin. Then how many finger breadths are they? What is the measurement? And then after that, she will measure. So this is the process of palpation. This is the proper method of palpation, and in this way you have to do the measurement. Okay, now the fourth step, that is of percussion. Now you have to percuss the, as you have already percussed the liver and the spleen, now you have to percuss the bladder from midline downward. Then you have to look for the shifting dullness, and then for the ascites and the fluid thrill. Now this video will show, first of all, you always have to do the shifting dullness because it is present in moderate ascites. Fluid trill is also always present in severe ascites. In fluid trill, what you have to do, you have to place one of your hand on the flank of the patient and place a hand of any attendant of the patient in the middle, and with the other hand you have to tap the abdomen. If there is any fluid present, you will feel it on the hand that you have placed on the flank. Now she'll be doing the shifting dullness. You have to place your hand at the middle of the abdomen and you have to tap the finger from midline to the flank, and if you find it dull, then you have to tell the patient to shift to the lateral side and wait for a few seconds. After that, percuss again. If it is resonant, this means the fluid dullness was positive. Now the fifth step was auscultation. Now in auscultation, you have to auscultate the bowel sounds, and bowel sounds of normal intensity are usually audible in the right iliac fossa. Any venal brew if present, and it is audible in the venal stenosis, hepatic brew that is present in hepatoma, venous hum that is present in the epigastric region, and that is due to the turbulent flow of the collaterals in the portal hypertension, aortic brew that is present above and the left of the umbilicus in aortic narrowing, and the splenic rub that is present in splenitis. Now after the first step, that was the general look. The second step was abdominal exam. Now the third step, that is the relevant GPE. In relevant GPE, start from the hands, look for any leukonychia, paronychia, clubbing, palmar erythema, pallor, hysterexis, wrist widening. Then find the pulse, see their weight, the rhythm, volume and character. Then see the BCG scar. If it is present or absent. In head and neck, you have to look for the hair, the AF, the eyes for pallid jaundice or white spots, mouth for glossitis, ulcer, etc., JVP and thyroid. Then palpate the lymph nodes, and then look for CVS and chest for heart failure, for the rosary. Look at the legs for any pedal edema, and the back for lung bases, sacral edema, and the wasted buttocks. The fourth thing, that is the genitalia. In genitalia, seek permission and examine the genitalia for tender staging and scrotal swelling. The fifth one is other. You have to offer at the end of examination if you have time left. So you have to measure the vitals, then anthropometric measurements, fundoscopy, slit lamp examination, development assessment, neurological exam, and joint exam. Now, what will be the differentials? In CLD, if a patient comes with CLD, what will be your differential? So differential will be four main things. The first one, that is Wilson disease, autoimmune hepatitis, drug-induced hepatitis, and viral hepatitis. This was the part 1 of approaching a patient with CLD in an elder patient, and in a while we'll be uploading the second part 2. Thank you. I hope you have enjoyed.